Hello everyone, welcome to the presentation. Presentation is about basic life support. I am Kannan Balaraman. I am a maxillofacial surgeon from Coimbatore. I work in a hospital called Ganga Hospital. What is basic life support? As the name indicates, basic life support is something which is quite basic, which anyone and everyone can do. It doesn't need advanced techniques. It doesn't need highly skilled medical personnel to do. All it needs is a motivated person who knows the technique and who is willing to do the technique systematically so that it can help a victim or a collapsed individual. So this lecture, idea of this lecture is to introduce you to the basics of basic life support. As you know, the part of basic life support BLS is also cardiopulmonary resuscitation, or something what we call CPR. Cardio, as you know, is heart related. Pulmonary, as you know, is lung related. Resuscitation is revival. So we will give you an idea of how the CPR techniques have evolved over time, and also discuss about the current guidelines of CPR, how they have subtly been altered. And finally, the technique of cardiopulmonary resuscitation with a note on AED, automated external defibrillator, which is also part of BLS in the recent decade. Look at the background of this presentation, or why CPR. In this context, we have to acknowledge the immense contribution of American Heart Association, who are at the forefront of formulating the guidelines of CPR and also disseminating this knowledge free to almost everyone. However, the actual training of basic life support with the licensing of American Heart Association requires a charge, because they give you the study materials and they use this to research and disseminate the knowledge. So if you want a certified program, a program of BLS, which is certified by the American Heart Association by experienced people, then there is a charge involved. Otherwise, the knowledge is, both the journals and the literature is available free of charge for everyone, not only clinicians. We are even looking at common public can download and read it. The guidelines come in a journal called Circulation, which is the endorsed journal of the American Heart Association. So if you look at the status of cardiopulmonary resuscitation in India, why it is important. Looking at the current demographics of India, statistics say that every 2,000 people group may witness a cardiac arrest. So what is cardiac arrest? Something like heart attack. So if somebody experiences heart attack, the heart stops and it doesn't function anymore. So at that time, we need to give first aid, and the type of first aid is what we call basic life support. And part of the basic life support is CPR, cardiopulmonary resuscitation. If a person who is next to the victim or next to the patient who has had starts the CPR immediately, the chance of survival of that individual is quite high. You're looking at 60% chance of survival if the CPR is initiated within the first minute, or max within the second minute. However, if there is a delay of initiation, the survival chances start decreasing, and if it's more than 10 minutes, the chance of survival is almost negligible, and the quality of survival isn't great. Now, at least with the data presently, only 1% of the Indian population know how to perform actual CPR. That means less than a crore. Though a crore number is a huge number, if you look at the context of the Indian population, it is not that great. The World Heart Federation gives us this data, whereas the technique of CPR, the principles of CPR, is given by the American Heart Association. So what is the basis of it? Imagine an electric pump, or any pump, a mechanical pump, which is working 24 hours a day, 7 days a week, 365 days a year. There is no pump which has been designed by man which can continuously function, except a biological pump which is within man or any living being, that is the human heart or the animal heart or whatever, which is part of the circulating system. The role of the heart is to pump blood to all parts of the body. The heart, so it does two things. One is pump blood to all parts of the body, and then receive blood from there to all parts of the body. So basically it sends blood to the lungs, get it purified, and the oxygenated blood has to flow to all parts of the body, and then the used blood comes back to the heart, goes to the lungs. So this is a continuous process, and it can't stop for me. If it stops, then the circulation stops. Therein lies the problem. Why the problem is, the heart stops, the brain is not going to receive any oxygenated blood. Brain is quite finicky. Human brain without oxygen or glucose for more than 4 minutes can go into irreversible damage, and that is a problem. And that is why you want to do immediate first aid and take them to the hospital. Taking them to the hospital is going to be a while, so if you start doing first aid to minimize this brain hypoxia and hypovolemia, as we say. So the aim of the lecture is to look at what to do when we have a collapsed victim, how to perform the actual technique of chest compression and rescue breathing, which is part of CPR. Chest compression, cardiac associated; rescue breathing, respiratory associated. We'll also discuss about the AED device, which is nothing but the automated external defibrillator, how it is incorporated into BLS in the last decade and how it has helped in the survival rates. And then last but not the least, we look at how to position an alive patient but who is unconscious, what we call recovery position, so that he doesn't end up harming himself by aspiration or choking. We will also look at how to assess and manage a patient who is going to choke in our dental clinic. Remember, this is part of the lecture series which is looking at medical emergency management in a dental clinic, and this is how to exactly manage the emergency. The previous one should have looked at medical situations. Here, at the end of any medical situation, if there is a patient who is not responding to you, then we go into basic life support and start CPR. If you look at CPR per se, CPR or cardiopulmonary resuscitation, what we call, though it was not called like that in the previous day, has been attempted by medical people from time immemorial. The commonest one is whipping the victim with stinging nettles, so that thorns, so that it stimulates an unconscious patient. So somebody who is hypoxic, hypovolemic, or who is unconscious may be stimulated, but not a dead patient. But at that time, the understanding of physiology wasn't great, but all they could do is anybody unconscious, not responsive, they could try and stimulate. And the only way they thought was pain. Pain, as you will know, is a very powerful stimulant, but not with somebody who is dulled, who is hypoxic. Over the millennium, as time evolved, from the development of Renaissance period and the industrial age, when Europe became industrialized, we had bellows blowing air into the furnace so as to melt iron, which could be done as a cottage household industry. So when bellows came, people understood that you could pull air from the atmosphere and push it into a particular area, and they used that to push it into individuals. This, when they realized an individual is not breathing, air is not going in and out, and they attempted to push it. Though it has been recorded over a few hundred years, the actual description is by the Swiss medical man Paracelsus, who was first explained this. As we go on towards the 17th century, 18th century, bellows was there. See, remember, when you are using bellows, you are only looking at the respiratory aspect. We have not discussed the cardiac aspect of resuscitation, because the understanding of heart physiology wasn't great at that time. So as the industrial revolution progressed, remember, it involved a lot of mining. Scotland was a place for a lot of coal mines, and at the depth of the coal mines, people used to feel suffocated. With the fumes coming in as they were digging for coal, they could get choked and they could die, or they could be asphyxiated. So as part of saving these trapped coal miners, the local surgeons there attempted mouth-to-mouth resuscitation, as described by William Tossac. At the same time, even if you look at the French literature, France is comparatively as good as well. French literature also described mouth-to-mouth resuscitation for drowning patients. So both are addressing only the respiratory issues. We have not looked at the cardiac issues yet. However, the first evidence of cardiac issue was described by a Danish veterinarian in chicks. So though the full physiology of heart wasn't understood by us, let alone animal physiology was much more understood than the human physiology, obviously, for the difficulties of dissection and getting and understanding them. So with the chick, he tried stimulating the chick, and he could elicit a beat, just a single beat. So and that was reported in literature. So that gives us some evidence that there is some other activity apart from just the breathing alone. So a lifeless chick was shocked, and then they could elicit some beat. So that they felt is not breathing, something else is happening, and then they understood it could be the heart. However, with the late 18th century until the 20th century, there was not much clear-cut idea of the circulatory physiology or how to address it. So patient positioning was considered important. An unconscious patient, remember, will choke on himself. The idea was to make sure that he doesn't choke and he continues to breathe, whatever you are using. So either the Hall method involved positioning them laterally, though it was quite awkward, and you could see that positioning them on a mass of sheets or bed so that the head tilts down, so that the saliva flows down. Remember, when somebody is lying back, tongue falls back, saliva goes back, and they choke in an unconscious patient. And another method was chest pressure arm lift method. They thought that increasing the chest pressure will help in an unconscious patient. They couldn't understand how to increase the pressure. Only thing they did was raise the arm so that the chest expanded for them. And so these were the two things which were advocated. And these were difficult scenarios. And if the clinician, if the medicine man was called to the area or he witnessed the arrest, he tried it. But when he went there, the arrest was already happened, the patient was not responsive, and they were cold and uncommunicative, then it was left and declared dead. In the late 19th century, it was a German surgeon, Dr. Friedrich Maas, who came up with the concept of chest compression rather than ventilation alone to help with the resuscitation. The external compression was what he described. Though the description was okay, it didn't take much traction. At that time, some people, though they understood the concept of compression and circulation, it was direct open heart massage. That might mean cutting open the chest, doing a sternotomy, and compressing the heart with the fingers. So that was quite drastic, as you will know. In an already collapsed patient, you cut open the chest, is going to bleed even more, and you are stimulating the heart, is not going to respond even more. The chance of success was less. But remember, these were already dying patients. The concept of external massage didn't take traction. Difficult to specify a reason why, other than the fact that we could tell that people didn't understand the concept. Now, why is this circulation coming? But at least the evidence that heart has to be stimulated to squeeze the blood to other parts of the body. In the beginning of 20th century, from the Americas, American medical team started progressing much more. George Crilley, this is a name which will resonate very much amongst maxillofacial surgeons, especially interested in cancer care or any oncosurgeon. He was a prolific surgeon with specific interest in cancer, head and neck cancer. There are incisions in his name. So, head and neck cancer, remember, could lead to choking and aspiration and a lot of deaths, and it was quite fungating death. And so Kelly was associated with resuscitating them. As part of his research, he realized that external compressions were effective, and he demonstrated that in dogs. External compression of the heart was effective. He also tried proving that in humans. Though he was successful in one case, it didn't get much traction because it was not quite popular or the physiology was not as clear cut. Still, open massage was an option for all the people to follow. The current concept of cardiopulmonary resuscitation and the techniques and principles of resuscitation owes its moorings to the establishment of American Heart Association. It was formed in Chicago in 1924. We are almost close to 100 years there. It started as a professional society for interaction amongst cardiologists to discuss their cases, discuss concepts, and propagate knowledge. So we are nearly a century there, and I think it's the guidelines of American Heart Association which has been a trendsetter for CPR training and also basic life support and advanced life support principles. The American Heart Association takes pride in evaluating them and trying to address these issues constantly. So they lay emphasis on training, education, and dissemination of the knowledge. All the knowledge, all the research is published in a journal which is affiliated to the American Heart Association, the journal called Circulation, and all the literature pertaining to CPR and basic life support is free for everybody to download and read. Not only medical people, but also common man. So that is the service of American Heart Association. American Heart Association lays out its principles for free. However, if you want a certified training, meaning a training in BLS or ACLS, certified by AHA, where they give a certificate saying AHA, he's done an AHA accredited course, then it needs to be, it carries a fee. They give you a lot of study materials to support that as well. As external, then as the AHA understood the concept of physiology, they propagated the external cardiac massage also, like compressions of the heart. As we came close to the Second World War, and after the Second World Wars, the medical field started evolving greatly, and in Cleveland, Ohio, Dr. Claude Beck demonstrated the first successful use of a defibrillator on an exposed human heart. Still remember, a lot of open heart surgery and manipulation was still going on. And the current concept of appropriate mouth-to-mouth resuscitation, not the bellows, not blowing, current concept of how to position mouth-to-mouth and how to breathe into the victim's mouth. The basic principles of it was established by Dr. Elam and Peter Safar, and they proved to everyone that how effective this method is if done properly and appropriately. The United States military, the United States, as you know, started becoming the premium world power at that time, and they took pride in disseminating not only medical care and also medical care to all their troops all over the world. Remember, American troops traveled all over the world, so they had to send devices all over the world, and this needed to use the external defibrillator. A portable one was also designed by the Johns Hopkins team. The US military adopted guidelines for mouth-to-mouth resuscitation as well. So once they adopted the guidelines, the training is disseminated to everyone, and whoever American military interacted with, they were also taught about these techniques, and then these techniques started taking root and spreading all over the world. In the 60s, we hear of the famous story of resuscitation, wherein a common man, an engineer whose daughter was unwell, when he took her to the casualty in his state in the US, he found that the people weren't quite trained in doing, and there was a lot of confusion and pandemonium in trying to resuscitate her. So when he spoke to the clinicians, he found that setting up established protocols helped, but the problem is reading them alone and trying to practice them is very difficult. So you need to have practical sessions to improve your skills. BLS and CPR techniques are something akin to techniques like riding a bike, swimming, or driving a car, which emphasizes that trying to practice them or trying to do things practically helps with the technique. Only reading doesn't help. And once he understood, he designed a mannequin on which people could practice, and the mannequin was named Resuscitation. Anne is in memoriam of his daughter who passed away unsuccessfully. So therein lies a man who took umbrage at the way things were, and it decided to turn or help the system there, and hence Resuscitation was born. So it is in the 70s in Seattle, again the Americans led the way, how to start propagating the knowledge of CPR, and they started incorporating the training for common public as well. They understood the importance of early resuscitation in people, and they started training people, trying to make the language in a simple way so as to disseminate the knowledge. So their goal was to spread it to as much people as possible, and they kind of succeeded in their goal. If you look at the numbers over the first 2 years, because more than 100,000 people, or 1 lakh as we call it here, did. So as an offshoot of the cardiac life support program, pediatrics department, as you know, they take pride in applying principles of care and protocols and pathways of training for pediatric patients. They adopted the BLS to the pediatric population, what they call pediatric BLS, and the adult became pediatric adult life support, or commonly called PALS. And an offshoot of that was neonatal, newborn resuscitation as well, when a newborn doesn't respond well. So we can see how the essence of CPR and basic life support has evolved over the years. In the 1990s, external defibrillation concept had come and it started gaining traction, and how it could be disseminated into public space was there. Now there are AED machines all over in public place. In our country, it's gaining traction. And remember, in our country, all five-star hotels, all airports, all public spaces should have an AED machine, or they are trying to come there. The government is trying to push it. NGOs are trying to push it. For example, in our city, Coimbatore, the hospital, our hospital, Ganga Hospital, Rotary Club of Coimbatore, it is the oldest club in the city, and the companies, private partnerships with companies like Philips, have come together to establish and set up AEDs in almost 13 to 15 places in the city, in public places like bus stand, railway station. There are 3 different bus stands in everywhere, and 2 railway stations everywhere, and even in the jail. So not only leaving this physical infrastructure there, but also training the public, training the core people there into the usage of AED. Otherwise, it just becomes a box. AED, again, to reassure, is automated external defibrillator. So from then on, guidelines were incorporated for appropriate CPR. Remember, it's come to the public domain, and we have got not only the physical technique of external compression and mouth-to-mouth breathing, an added component of AED, a shock machine has been given. We will understand and discuss about the shock machine as we come to that concept. So from 2005, 99 it started. In 2005 we had the guidelines, and then the current guidelines, every 5 years the guidelines undergo a thorough revision. Every 2 to 3 years they undergo an update. So the guidelines which we follow now are 2020. Initially, when it started in 2005, 99 and 2005, as it evolved in this century, it incorporated ABC, airway, breathing, circulation. And when you approach a patient, this was what done. You approach, look at the airway of the patient, look at his breathing, and then look at his circulation. Now there is a subtle change. The concepts of how many compressions to how many breathing to give was done. That is 30:2. All that came about with this guidelines. And these guidelines were universally applied all over the world, not only in one country, all over the world. Feedback was sought by them, discussed again, and then evaluated periodically. In 2010, again the sequence was ABC, and then the concept of 30 compressions to 2 for a single rescuer or 2 rescuer in adults, it changed. Whereas in kids it became 15:2. In 2015, the compressions wanted to concentrate more on the compression. So from 100 to minute, they said you could go more than 100 to 120. Whereas the guideline initially was 4.5 to 5 centimeter, became 5 to 6 centimeters. And from 2050 onwards, the sequence changed from circulation, airway, and breathing. So from ABC, it became circulation, airway, and breathing, meaning compression started getting more attention. Why did it come about? Initially, it was airway, breathing, circulation. In ABC, it was a nice mnemonic. Everybody could see. You approach a victim, see if his airway is intact. Like see if there's blood in the mouth or something, you clean it. Look at his breathing if he's breathing, and then look at his circulation by pulse, and then start compression. Whereas now, in an adult, we know why an adult collapses or becomes unresponsive because his heart attack. Whereas in kids, it's mostly airway. In a drowning patient, we don't need to do this, but in a patient who is not drowned in water, if you see him outside, most likely it's cardiac arrest for an adult. And that's why it has become CAB. It is a subtle shift, and we will see how it goes. The ratio of 30:2, meaning 30 chest compressions to 2 breaths, is the same for adults, whether single or many people who can do CPR are present. Whereas in kids, there's a single person, you do 30 compressions to 2 rescue breaths. Where there are 2, it can come down to 15:2 because breathing is more important for kids. The chest compression has to be at least 2 centimeters. What we are meaning by chest compression is we are externally compressing the chest. When you compress a chest, the rib cage goes inside. When it goes inside, the heart is within the rib cage, it gets compressed. When it gets compressed, whatever blood is within the heart flows out to everywhere. Then you relax, as in the B, picture B. So whatever blood is in the veins get filled into the heart again. Then you compress again. So you do that, you do it in such a speed that it is 120 per minute. So meaning every second you are hitting 2 and you count out loud. So you don't take your hands off the chest, the hands are in continue with the chest, and you press with the heel of the hand. The actual technique we will see again later. So whether you are a in-house hospital healthcare provider or out of hospital other healthcare provider, an independent healthcare provider, the principle is the same. If you see them in the hospital, you recognize them, alert the emergency medical system before you perform CPR. If you see somebody collapse, don't jump to CPR because you might not get any help. You have to get some help. If there's no help around, you go and make a call as to who's going to come. If you're out within the hospital, there is an emergency medical team and there is training for the emergency medical team to reach to the area of problem. If there is a ward in one corner of the hospital, if the command is activated, the emergency medical team reaches there and to perform CPR. We don't want to wait to take the patient to the critical care unit. Similarly, in the outside world, the same thing is followed. You call an ambulance and an ambulance comes. As the emergency medical team comes or the ambulance comes, we start doing CPR for them so that we can keep compressing. So we are compressing the heart, giving the breaths, like they say 30:2, but the speed of it is like it is 100 per minute. Till the medical team comes and takes over or the ambulance comes and takes over, and then they go to the hospital and they get appropriate care. They can revive the heart, well and good, and they survive. In the current day and age, it is mandatory to know the techniques of appropriate CPR and then do the techniques so that we don't mess up the patient. There are two components of cardiopulmonary resuscitation. One is called BLS, which is basic life support, and the other one is ACLS, advanced cardiac life support. As basic healthcare providers, it is imperative that we know what BLS is and the technique of BLS. ACLS requires specific training and certification as well, and that is essential for people who, like anesthetists, cardiologists, or surgeons who are in critical care work, or anybody can take it, even if you are interested. But it is mandatory for us to take basic life support. As we saw, the change in the current guidelines from airway breathing circulation to circulation airway breathing, because compression is the first component nowadays, especially for adults, and give defibrillation, the shock machine, as much as possible. If you are the only person, go make the calls for the ambulance if it's outside or the emergency system in the hospital before you come and initiate CPR. Do your checks of pulse and breathing and start the process.